Okay, so I'm just gonna do my head to toe sort of newborn assessment here. So what I'm gonna do is that I'm just going to say for my scenario is that the baby's gonna be in the bassinet. That's what I saw in the clinical setting. So then I've washed my hands, and I've also learned that to wash my hands in under warm water. So you want to start with the baby when your hands are cold. So that was a really good teaching I learned from my instructor. So then I'm just gonna try to do as much of hands-off assessment as I can. So the baby would be in a bassinet. I'm just looking at the baby. I'm just assessing, like, are they breathing? Is they're breathing? Yes. And if it's regular and irregular, good. Okay, so then I was just like, look at their face, the facial symmetry. It looks like they have two eyes and an ear, just looking at that. Okay, so then I would just move on and start with my head. So then I'm just, even though I'm not doing I'm trying to do a hands-off assessment, I would do my vitals in just like the way I would work my head to toe. So then I was just like, look at the baby's head, okay. Make sure there's no trauma to the head, especially from forceps or some sort of like scarring on the head, and then just note of that if there is any. Okay, so then I'm just going to palpate for the fontanelles, the posterior one. It should be like triangle shaped, usually roughly like half a centimeter, and then the fontanelles at the anterior is usually, I think it's half a centimeter to like 3.5 centimeters, so this one's more of a diamond shape. I'm just assessing if it's sunken, and that could be a sign of dehydration. If it's bulging, that could be a sign of intracranial pressure. So then from then, I would just go ahead and then do the rest of my head assessment. So making sure that the baby has two eyes, it's equal reactive to light, and what type of measurements they are. I won't do that. But okay, yeah, assessing any like kind of trauma to the eyes, making sure there's two eyeballs in there, and that there's no sclera or yellowing, which is a sign of jaundice, so that's good. So next I would just assess the baby's ears, making sure there's no skin tag, they're both symmetrical in shape, and its alignment, not too far down or not too far up, so that's good. And then next I'm just going to assess baby's nose, making sure it's clear there and it's clear from the looks of it. There's no redness or any swelling or any signs of kind of mucusy, possibly from the amniotic fluid. Then next I would just check baby's mouth, making sure, like the lips, assessing inside, and putting my finger in there, and I'm assessing that there's a tongue and it's not tongue tied, and then checking the palate, the soft and hard palate, and making sure there's no cleft palate as well, where there is where it's not formed on the top, so that could be abnormalities. So then next, after assessing the head, I would move on and try to work my way down. So I'm assessing the neck, so if there's any tracheal tugging there, no, there's not. So I'm just gonna quickly try to get my respirations and to feel and to listen to any abnormal adventition sounds on the lungs. So I would count the respirations for a full minute, and as well as it's 30 to 60, which is the normal. So then I would do it, auscultate anteriorly, and then auscultate laterally for those adventitious sounds. If there's any crackles. So next I would move on to check baby's heart rate, and I do that for a full minute. And the normal range would be like 100 to 160 beats per minute. And if it's regular or irregular, and also I'm just going to check for any murmurs that the baby could possibly have. Okay, so after checking that, and then I'm just gonna feel for the baby's clavicle, making sure that, after giving birth, like they could be squished, so then making sure there's no broken bones, feeling for that, and that, okay, and then the ribs, feeling for the ribs. Okay, yeah, there seems to be no broken bone. Just assessing any symmetrical, and then as well as perfusion on the chest. Okay, and I'm just gonna check for the femoral, making sure it's present, bounding, and as well as any brachial possibly can. Okay, good. From there, then I was just like listen to the baby's bowel sounds. And if there's bowel sounds present, in all four quadrants. And then next I would just assess if there's any scars or any lesions. And then I would just palpate to feel out for any masses, not too hard. Okay, so that's good. Okay, so after doing that, then I'm also assessing that if the baby is crying at this point or possibly being fussy, knowing that they have good posture and the reflexes. Okay, they'll have two hands and just checking like their fingers, 1, 2, 3, 4, 5, 1, 2, 3, 4, 5. So then they have 10 all together, making sure there's no webbing. So that's good. So then I would just like move on and try to assess for the down here, assess the feet, making sure there's 2 and the same in length. There's a knee, and then making sure the toes, 1, 2, 3, 4, 5, 1, 2, 3, 4, 5. Okay, so there's 10, so that's good. So after assessing the zones, making sure there's no acroceniosis, which is common like 24 hours once the baby's been delivered. It's just because like maybe the oxygen's trying to get into those extremities, and then it's just taking its time to do that. So after that has happened, then I would just check for, and then I would just flip over the baby at this time. It's really important to teach parents about tummy time and getting them to be on their stomach, and then establishing that routine, whether it be like 20 seconds or like 30 seconds and a full minute and then 2 minutes, and then you can really assess their neurological and as well as some reflexes. Then I'm just gonna check baby's neck, okay, and some sort of like spine, making sure all the spines are there. And also I've learned that at the very end point, it should be closed where there's like the sacrum from my instructor, so that should be closed. There's no opening that could possibly create some complications. Looking at the bumps, if there's any rashes on the buttocks, and note some sort of discoloration. Okay, so after that, check that, assess the legs, the back of it, so they're on tummy time, and then we're just moving back to on here. So then after that, then you would just also with the reflex, are they crying? Is the posture they flexed? Is the baby's cry, is it good, or is it kind of like high pitch? Just assessing their normals. And then with the urine, is that once I'm checking the diaper, then it's important to educate parents that the first void is it's one for the first 24 hours is one diaper, and then one wet diaper, and then after up to a week old, then they could have multiple. And then just with the first few hours or first 24 hours, there could be like orangey color urine, and that could be like the urine crystal trying to just excrete itself. Hey Zuri. And then with the bowel movement as well, meconium is common 24 to 48 hours, and then it could be like green, black, sticky stool, and then it transitions to 2 to 5 days of age, and then like breast milk stool is like soft bright yellow, seedy or curd like, and then formula stool is like dark yellow brown, and then like at least 1 per day. So just inform mom that after birth that there could be experiencing like 10% weight loss, and then babies can regain this like 2 to 14 days, so it's normal as long as they regain the weight. And then as well as I'm just gonna measure them the circumference of the baby's head, and the normal head circumference is I think 34 to 37 centimeters, and I think the length should also be measured. It's like 45 to 55 centimeters. So I think that's it. Just important to teach parents of like some sort of like baby's feeding cues. Oh, and one thing that I also forgot was the umbilical care. So like per diaper change, we should be assessing the umbilical cords, assessing for any like signs of infection, such as like purulent discharge or any redness or swelling around the site, and just cleaning it with a Q-tip and some water well per diaper change. And then yeah, I think I would just cradle the baby, and just some important like reflexes that babies have, such as feeding cues, is that babies should be sucking or going like this, or I don't know, if they're just hungry. They shouldn't be crying just to wait to feed, and they should be feeding I think like 1 to 4 hours, so like 8 hours maximum in 24. So I think like it's really important to understand your baby and know its normals and know how to console it. And yeah, I think the only thing that I have left was taking the vital signs. So I would measure the baby's temperature. So I didn't do that. So I would measure the baby's temperature in the axilla, and the normal range is 36.5 to 37.4, which is really in strict parameters, and we would take it 3 times consecutive if it was not in the normal range, to make sure it's normal. And as well as we do the respiration for a full minute, and the normal is 30 to 60 respirations, and then the heart rate is 100 to 160 beats per minute, and we take it for a full minute as well. And then for the SpO2, I was just taught recently that we only just monitor it for critical congenital like heart disease, which is done for screening on newborns of 24 to 36 hours of age, and then as well as the blood pressure is not routinely done on maternity floor. So that's what I was only taught. And as well as when I was in clinical, I'd given baby vitamin D for supplementation, because I think like it helps with bone growth development, and as well teeth development. And then normally living up north, I don't think we get enough of sunlight, so that's why it's given through pharmacologically. And then just like teaching parents and how to give it and administering it, and like the importance of getting the appropriate vitamin D that helps the development of growth and development of their babies. And sorry, I just forgot to add that with babies, you also want to assess their reproductive. So like when doing your diaper change, you want to look for any rashes. So with this baby, she is female baby, so then you would just assess baby's labia minora and labia majora, and then if the pseudomenses, which is the white stuff, just reassure parents that it's common. And then also as well with boys, is that you want to also look at their testes and then their penises, and making sure it's intact and then it's nicely dry, there's no redness or swelling around the site, and palpating for the testes, which is really important. The other thing is that babies also elicit some kind of reflexes according to their development. So then they're gonna do some brooding, which is where you go like this, and then as well they're gonna be sucking reflexes, and then as well as they can grasp on your hands, and then as well as the Babinski, where you just like the fanning of the toes. So you just elicit a reflex, and the toes should fan. And then the last thing is a more reflex, and when like, so you hold a baby like this, and then you just drop them down, and they should be able to like kind of hold itself like this and catch themselves. So that's just like some reflexes that I forgot to talk about, and that's it.